Hi, this is Jayla and Jenny, and we are covering cognitive behavior therapy and task-centered model, and we are going to first cover cognitive behavior therapy. Aaron Beck developed this form of psychotherapy after identifying that his patients with depression often verbalized thoughts that were lacking validity and noted characteristic cognitive distortions in their thinking. We also learned in class that other major contributors were Albert Ellis, Albert Bandura, and B.F. Skinner. Cognitive behavior therapy, known as CBT, has been extensively researched. Clinicians and researchers have developed CBT treatment protocols and have studied their effectiveness. Studies have shown that CBT has been effective with depression, anxiety disorders, eating disorders, substance abuse, and personality disorders. It has also been shown to be effective for individuals with serious mental health disorders such as bipolar disorder or schizophrenia with the combination of medication. Our thoughts, feelings, and behaviors are all connected. This is a great tool to utilize when working with a patient. We are going to talk about Ruth and her thoughts, feelings, and behaviors about a particular situation. So Ruth wants to be a professional baker. Her thought, I am not good enough to be a professional baker. Her feeling would be discouragement, self-doubt. Her behavior would be giving up and not trying at all. And giving up can be a way for an individual to protect themselves from disappointment. By not trying or challenging the defeating thoughts, the negative cycle continues. But at the bakery where Ruth works, her supervisor encourages her to take culinary classes to improve her skills. Her boss also tells her she is doing a great job and that it can take time to learn all the skills needed to be a professional baker. After hearing those words from her boss, Ruth's new thought is, my boss thinks I'm doing a great job and is encouraging me to pursue becoming a baker. Her new feeling would be excitement. Her new behavior, applying to schools that will help her reach her goal. CBT is based on straightforward, common sense model of the relationships among cognition, emotion, and behavior. Let's explore automatic thoughts, cognitive distortions, and underlying beliefs or framework for cognitive behavior therapy. Automatic thoughts are an individual's immediate, unpremeditated interpretation of an event. The thought shapes both the individual's emotions and their actions in response to the event. So an example is you're walking down the street, you see a friend, you holler at your friend, hello, they don't acknowledge you, they don't wave, they keep walking. An automatic negative thought would be, I'm a bad person, they don't like me, they're mad at me. Somebody who doesn't have that automatic negative thought might be thinking, oh, maybe my friend's having a bad day, or maybe my friend didn't hear me. Cognitive distortions include overgeneralization, selective abstraction, mind reading, fortune telling, personalizing, blame, emotional reasoning, catastrophic thinking. Those are just some of the cognitive distortions. There are some more. Overgeneralization, that is taking an isolated case and using them to make wide generalizations, such as she talks on the phone all day long, or using the words never and always. Selective abstraction is focusing on one aspect of the situation, usually focusing on the negative, upsetting part and ignoring the rest of the situation. Mind reading would be assuming the thoughts or intentions of the other. Fortune telling is predicting how things will turn out before they happen. Emotional reasoning would occur when making decisions and arguments based on how you feel rather than objective reality. Catastrophic thinking is focusing on the worst possible outcome, the worst case scenario, even when it's unlikely to happen. Next is underlying beliefs. So core beliefs are firmly embedded in our thinking and shape our reality and behaviors. These are strong, long-term beliefs and guide how we see ourselves and perceive situations. Core belief examples: I am smart, I am trustworthy, or a negative core belief example would be I am unlovable or I am stupid. Intermediate beliefs: their assumptions, attitudes, and rules. They're influenced in their development by core beliefs. And intermediate beliefs can be more specific, such as, if I am thin, then I am pretty. CBT is a structured, teachable, and goal-oriented form of therapy. It is a hands-on approach and practical. The therapist and the patient work in a collaborative manner with the goal of modifying patterns of thinking and behavior to bring a beneficial change in the patient's mood and the way of living his or her life. It is used to help a wide range of problems. CBT can be customized to meet the needs of the patient. Health and Human Services of Texas has a great resource that outlines the goals and guidelines of a CBT session. While the average amount of CBT sessions range between 10 to 12, the Health and Human Services of Texas provides guidance for 16 sessions. When meeting with a new patient, it is important to build rapport. Taking the time in the first session will build trust and confidence for the patient. An assessment will need to be completed and educate the patient about the CBT model. Converse with the patient in normalizing their difficulties while instilling hope. Discuss the problems the patient wants to address and develop the goals. Next, we are going to cover cognitive behavior therapy interventions. This first intervention is Socratic questioning. This type of questioning derives from Socrates, who would use the art of conversation to push the dialogue forward by asking focused, open-ended questions that encouraged reflection. The use of Socratic method by CBT therapists helps clients become aware and change or modify their continued difficulties. This slide shows an example of Socratic questioning. So first question, therapist, imagine that you believed that dogs were dangerous and you saw a dog. What would go through your mind? The client, the dog would bite me. Therapist, how would you feel? The client, nervous and anxious. Therapist, what would you do? The client, I would avoid the dog. I might even run. And then the therapist switched. Now imagine you believed dogs were cuddly and safe. What would go through your mind? The client, I suppose I'd think, oh, he looks sweet. And then they continue the line of questioning. And so this helps with that focused, open-ended questions that encourages the client to reflect on their thoughts. Other CBT techniques include reframing the way an individual thinks or perceives a situation. Journaling thoughts in the moment when a situation triggers a negative emotion or thought process the patient is trying to overcome is also a good technique. Taking time to reflect on the situations. Mindful stretching and deep breathing techniques can be used to decrease anxiety and promote calmness. Another difficult technique could include facing something that is feared. For example, if somebody is afraid of snakes or spiders, they could look at pictures of a snake or a spider, and then maybe one day they could be at a place where the spiders and snakes are in enclosures and they can be across the room and look at them, and maybe one day they could even hold them. Now that may take a long time, but that is an example of facing the fear. Penny is a 28-year-old who reports feeling anxious and depressed. She has a hostile relationship with her mother since childhood. Penny saw her father at the age of 21 and did not contact him after that meeting. There were times in Penny's youth when she lived with her maternal grandparents. She had a good relationship with her grandparents. Penny did not have structure growing up when living with her mother. Her mother would often have psychotic episodes in public, causing Penny a lot of embarrassment and insecurities. Penny's mother also prevented her to fall asleep during psychotic episodes due to paranoia. The lack of boundaries in her home allowed her to act out and make shameful decisions. Penny's self-esteem was low, and at the age of 13 she attempted suicide. Her grandfather died when she was 15, and her grandma died when she was 19 years old. At that time, Penny was in a turbulent relationship and attempted suicide again. She was bullied in school and did not have close friendships. Penny describes her early 20s as being chaotic, and at the age of 18, she decided to try therapy again. Penny describes feeling depressed since being a teenager and socially anxious since her early 20s. Penny is in a relationship with a stable and supportive boyfriend. She has 3 close friends who also report having depression. Penny has difficulties with unfamiliar people and fears making a mistake in their presence. Since her teenage years, she has felt weak, awkward, bad, and stupid. Penny displays little compassion for herself and feels like a burden to others. Penny also suffered from chronic neck pain, resulting in missing days at work. Penny attended 12 CBT sessions. Her goals were to reduce negative impact of her early experiences by talking about them during the sessions, and to reduce current negative thoughts through use of weekly thought diary, and the thought diary was reviewed each session. And the CBT therapist took time with Penny to build rapport because Penny had had CBT therapy previously and it was not a positive experience. And so in sessions 1 and 2, the therapist took time to build rapport. She also emphasized the importance of completing CBT homework by recording 3 main points. What happened? That Penny have a compassionate alternative perspective, and what Penny would like to think and do if a similar situation arises again. In sessions 3 through 10, Penny would report her mood over the last week. They would review the thought diary. They would bridge from previous session and a chance to reflect. They would agree on an agenda for the next session and what memories would be reconstructed. Penny stated her social anxiety and depression and pain were reducing and she was missing less work. And Penny liked the format of the therapy sessions and wanted to continue in the same fashion. Sessions 11 and 12 were completed over the phone due to COVID-19, but Penny's core belief worksheets she completed revealed more compassion towards herself at the end of the sessions versus the beginning. The outcome measures and self-reporting indicated Penny's social anxiety, depression, and chronic pain had improved. Thank you for taking time to listen to the information regarding cognitive behavioral therapy, and I found some great quotes online, and one of my favorites was from Aaron Beck, that is, cognitive therapy seeks to alleviate psychological stresses by correcting faulty conceptions and self-signals. By correcting erroneous beliefs, we can lower excessive reactions.
And we will now discuss the task-centered model. The model was developed in the early 1970s by Laura Epstein and William Reed, and throughout the years this model has expanded, contributing worldwide. Cody and Lehman defined this model as a short-term problem-solving approach within social work practice. This model is used in a range of fields of practice which include mental health, child welfare, school social work, gerontology, hospice, healthcare, family practice. This model is used at all system levels which include individuals, families, groups, organizations, and communities. This model has also been tested and found in a number of studies to be effective. And this is just an example of how the task-centered model was used. Here within a school project where practitioners were placed in public elementary schools serving children who were primarily lower income families. And this is just an example of how the identification of problems and as well as the assignment of cases were completed by each practitioner. There are four important phases of helping when using the task-centered model with clients. Those four phases of helping include engagement, assessment, intervention, and termination. The task-centered model is designed to help clients resolve their problems as well as they define them. Changes in these problems are secured by developing and implementing tasks for these clients to complete. It is important to note that out of respect for these clients, they do have a right to self-determination, as well as this being emphasized when using the task-centered model as well within practice. Engagement is the first phase of which is used when using the task-centered model. Within this phase, it is important to develop a relationship with your clients while introducing them to the problem-solving process, as well as connecting them through a mutual commitment to help resolve their defined problems. Within this stage, it is important to express or explain early on that the focus will be determined by the client. Though clients may sometimes express one problem, throughout conversation, the worker may discover that they have additional problems as well that they can work through. It is also important that the worker explains that this time will be limited. Emphasis are placed on these two problems because they appear to enhance motivation, especially when it comes to involuntary clients. Assessment and data collection is the second phase when using the task-centered model. Within this phase, the important activity is to identify target problems for that client. Target problems have been defined as aspects of the client's lives of which they most want to change for themselves. Within the task-centered model, when using assessment, it is imperative that the client identifies these target problems for themselves. However, this does not mean that the client must be the only one to identify the problems or that the worker should refrain from mentioning target problems that have been identified. It does mean that the final choice of the focus of treatment will be determined by the client, as well as you remember that it is important to note that respect for clients' rights to be self-determining is also emphasized within this task-centered model. Intervention is the third phase of which is used when using the task-centered model. Within this phase, goals are determined by the client. However, the social worker helps to make the goals more measurable. For example, if the client's overall goal is to be more positive, the worker would help them to define being more positive. A useful way to do this is to refer to the manifestations of the problem that were identified during that specification. Within this phase, it is important to know that time limits usually range from 6 to 12 sessions. However, they can be as brief as one session. If more time is needed, contract extensions are considered. However, there must be evidence that the client is working to diligently resolve their problem. These contracts usually include a list of the target problems and goals, the number and the frequency of sessions, the participants, and fees if applicable. During this phase, it is important to brainstorm with the client possible actions that could be taken to alleviate the target problem. As a social worker, it is important to suggest alternatives and encourage the client to do so. The more number of tax alternatives, the better for that client. The client is also asked whether he or she is willing to attempt the task. As with target problems, it is important to remember that the client does have the last word in choosing tasks of which they would like to do. Intervention phase continued. Some specific interventions that illustrate range of cognitive behavioral therapy when using the task-centered model include behavioral activation, contingency management techniques, exposure therapies, response prevention, cognitive restructuring, self-monitoring, psychoeducation, anxiety and stress management, self-talk and coping statements, and acceptance and commitment. Termination is the last and final phase, of which is used when using the task-centered model. Within this phase, it is usually limited to one session. During the last session, the worker and the client both engage in final problem review, make plans for maintaining or enhancing gains, review their problem-solving process which has taken place throughout each session, as well as discuss their reactions to separation of services. It is important for the social worker to praise any accomplishments of which the client has completed throughout their time together. Within the following case study, we will be discussing Grace, who was a 58-year-old woman who had liver cancer. She'd been primarily confined to her bed for the past 2 months and had experienced increased difficulty in performing her daily activities of living. Her physician informed her that her disease was terminal and eventually would recommend hospice. The family met and discussed this, and she decided that although she could seek aggressive treatments and prolong her life a little more, dying with dignity in her own home was what she wanted. Shortly thereafter, hospice met with Grace and her family and signed her into the program. As a hospice social worker, it is not only their job to assist both the patient and the family in securing needed resources, but also to assist them with completing unfinished business. The first step in this case example was to initiate contact with the family, complete a psychosocial assessment, and with the assistance of the clients, define what goals they would like to achieve. This latter is based on a task-centered approach that was discussed by numerous of authors and practitioners. First step in completing Grace's unfinished business was to identify and define what she needed to do. Grace reports that she was afraid that with her death, the stories of her culture would die with her. She did not believe that her family would pass on their cultural heritage to her grandchildren because they did not know its importance. She reported that she also felt lost from her culture, which she wanted to regain her knowledge and connect to the American Indian community and share what she knew with her grandchildren. Grace identified two target problems within the session. The first was her decreased knowledge regarding her people. The second was her lack of knowledge as to where to gather this information. Grace identified two goals of which she wanted to achieve during this time. Her first goal was to contact the American Indian community to regain contact with her cultural roots. The second was to pass her knowledge on to her grandchildren. Since Grace was able to determine what goals she wanted to work on, the probability was high that she would achieve task completion. Grace and the social worker agreed to complete the first goal within 1 month. After that, goal number 2 would then be completed. Now that engagement and assessment data collection have been completed, it is now time for intervention. Grace and the social worker decide who will complete which task for goal number 1. Having limited knowledge regarding the American Indian community, the social worker chose to consult a Southern California Social Services Resource Guide, which had no listings that helped. Her practitioner task was to contact a friend at California State University, Long Beach, hoping to obtain referrals from him, which Grace would then follow up. Grace had a hard time retrieving help and resources by advocating for herself. The social worker was then provided with two special resources that were worth more than their weight in gold as far as therapeutic interventions were concerned. The first was a hawk feather, and the second was a desert sage bound in red yam. Raptors, such as eagles and hawks, play significant roles within American Indian cultures. They are generally seen as symbols for the spirit of the life and creation. These symbols are important in most, if not all, American Indian cultures. Desert sage is one of the several dried plants used in smudging or cleansing oneself in ceremonies by having the smoke of the burning sage cover all parts of the body, thus cleaning it before the ceremony. As intervention and goal setting continues, Grace's next goal was to pass the knowledge on to her children. The identified problem here was that she did not know how to do this. She and the social worker discussed several options, one of her being to write down her stories in form of a journal, due to her not owning a computer or typewriter. Another idea generated was for her to record her stories on a tape recorder. The problem here was that she did not have one. Grace decided that it would be easier for her to use an audio tape recorder due to her lack of energy. As the disease process progressed, she found it more difficult to engage in activities. Writing would expend too much physical and mental energy. The next step was to find her a tape recorder, which was discussed with one of her daughters. As Grace explained what she wanted to do, her daughter liked the ideas and within 1 week's time had purchased her mother a small handheld recorder. With this barrier out of the way, Grace set out to meet goal number 2. Grace completed 4 90-minute tapes. She began with her people's story of creation. She then told stories of her people's history and how they are today. Lastly, Grace talked about her own grandmother and the traditions and knowledge passed on to her. The sage was burned before this step and was began, and it was decided that the hawk feature would be passed on to her oldest grandchild. Shortly after completing goal number 2, Grace slipped into a comatose state and died a few weeks later. Grace was able to ensure that her cultural legacy would not be lost to the next generation. She experienced in hospice what we call a good death. She decided without pain, her and her wishes were honored. Although the social worker spent a considerate amount of time with Grace on achieving her goals, Grace was not the sole focus of the attention. As she grew closer to death, the social worker's attention turned towards her family. Family members made decisions regarding funeral arrangements and other matters, as the social worker continued to provide resources and counsel according to the family's needs. No termination happened during the death of Grace. The social worker continued to reach out to the client's family, providing them with additional resources of which they may have needed during that time period. Several components were essential to the completion of this case. The task-centered model or approach was used within a multicultural context. The client was involved with problem identification, intervention, and problem resolution. This case was successful due to its short term, while using a more traditional long-term psychotherapeutic approach would not have been appropriate due to the client's time left for her to complete her life's work due to being on hospice. This is one example of how task-centered approach can fit in almost any setting. Gerontology and hospice, for example. Saying her goodbyes, the family dealing with their impending loss, and making plans were all essential to this case's successful completion. However, the cultural renewal and her passing this cultural legacy to her daughters and grandchildren were the essence of the work Grace needed to accomplish in the few months that she had left. Grace brought the lessons of multiculturalism and ethnic sensitivity to life for a social worker as well as her family. Attached here are references of which Jenny and I have used. We hope that you have enjoyed our presentation over cognitive behavioral therapy and task-centered model. Thank you.